May I please request Dr. Asit Mittal sir and Dr. Suresh Jain sir to stay with us and chair the next session as well. The next session is on role of dermoscopy and imaging in contact dermatitis. And the speaker is Dr. Yasmeen Jabeen Bhatt, ma'am. May I please request you, sir, to please introduce our speaker.
Dr. Yasmeen Bhatt, she is Associate Professor of Dermatology, Government Medical College, Srinagar. She had number of publication and presentation, and she authored 25 chapters. So I invite Dr. Jasleen for her presentation.
Thank you, sir, for the kind introduction, and I congratulate Dr. Dinesh Mathur, sir, and his team for organizing this hybrid conference. So I'll be speaking on the role of dermoscopy and imaging in contact dermatitis today. Is my screen visible? Is my screen visible?
Yes, yes.
Okay. So this is the first slide. Is it visible?
Yes, it is visible.
Okay. So I have no financial disclosures. Well, we know that optical imaging devices are used in a lot of specialties of medicine for diagnosis and evaluation. And it is not much used in dermatology practice. But nowadays, some cutaneous imaging techniques are being used for the management of skin problems, and it remains a novel area for most dermatologists. Although it was started initially in the skin cancers, but its use has been extended to inflammatory diseases, including the eczemas. There are various techniques of skin imaging. The most commonly we use a photography of the skin, which varies from the visible light photography to ultraviolet to polarized and to digital photography. Then it's followed by the micro-optical modalities, which give a magnified image, but that's not too magnified. So the various modalities include the dermoscopy, high-frequency ultrasonography, magnetic resonance imaging, and confocal microscopy. Then we have the macro-optical modalities, which give a very higher view of the imaging. So we have in this optical coherence tomography, laser Doppler perfusion imaging, and spectrophotometry. So there are various advantages with these techniques of skin imaging because they are non-invasive, they are slightly portable, and they are relatively inexpensive, and they provide a rapid information which can help us in easy diagnosis. Now coming to the most common, that is the dermoscopy. We know it's done by a handheld tool, that's the dermoscope, which has an illuminating system, and we can see a magnified image through which we can see the structures as deep as up to the reticular dermis, and it records the images as well. So we can use a handheld dermoscope attached to a smartphone camera, or we can use the USB dermoscopes connected directly to the laptops or computers, or even to this mobile phones. Then what it does, it visualizes the subtle clinical patterns of skin lesions and subsurface structures, and it's a reliable diagnostic tool not only for establishing the diagnosis of various types of dermatitis, but it may help in monitoring the evolution, therapeutic response, and prognosis as well. Now, before we go further, let's understand what we see on dermoscopy of dermatitis. So it's very important to understand the histopathology, and accordingly we get the dermoscopic pattern. So once we have the plasma in the stratum corneum, we can see it superficially in the aerial view, because dermoscopy is the aerial view compared to the vertical view in the histopathology. So we see it as a yellow globule. The focal parakeratosis appears as various scales, the spongiosis as hypopigmented cotton wool blanche. Then irregular hyperplasia of the epidermis at occasional sites leads to irregular grouped vessels and grouped and patchy vessels. So we can see them patchily, not uniformly, unlike that of psoriasis and other conditions. And the other exudative changes in this layers of the skin are visible as excoriation marks or angulated pigment network or yellow orange surroundings. So this is what we are going to see in dermatitis, right? So the dermoscopy of contact dermatitis actually varies with the stage of the disease. Like in acute exudative lesions, we see mainly the yellow scales and crust, what we also call as the yellow clot sign, in addition to the red dots. And in chronic and lichenified lesions, we see focal white scales and dotted vessels in the patchy distribution, and the background color is more towards the whitish end. And with this, we can differentiate it from the other inflammatory dermatitis like psoriasis, pityriasis rosea, and pityriasis lichenitis chronica. Now, coming to this image is a case of an acute dermatitis. What we see here are these are the yellowish globules. So then we see the whitish scales. We see these patchy red dots, which are actually the vessels, and we see a dull orange background. So this is the case of the acute dermatitis. Now, compared to the subacute dermatitis, what we see here is again the patchy and irregular distribution of the vessels here and there. But there is more of the increased white scales and less of the yellowish globules. And some yellow seropress can also be seen here and there, and more of the excoriation marks can be appreciated. Once we move on to the chronic dermatitis, we can't appreciate any of the vessels here, no patchy distribution. And if you see more of the white and scales, few of the yellow scales as well, but there is more of the whitish background. Same is the case with the fingertip eczema, like we can see these yellowish scales and crust and patchy red dots and background whitish hue. So in case of hand eczema, we rarely see the red vessels, but we see more of the brownish orange dots of globules corresponding to tiny spongiotic vesicles, yellowish scales of crusts. And less commonly, we see the whitish scales and red dots. And we can easily differentiate it from psoriasis like lichen planus, keratoderma, and even tinea manum. So this is the early case of hand eczema, where we can see these as the brownish globules or clots, and there are the sparse yellow scales as well. So this indicates a spongiosis, and this is the hyperkeratotic variety of the eczema, where we see more yellowish scales and patchy red dots. And similarly, this is a chronic type where we see sparse whitish scales, yellowish scales, and brownish dots of globules. So this is the cumulative contact dermatitis. Then nails can also have some changes in case of chronic contact dermatitis, like we can see more of the perangal scaling, tiny pits here and there, and transverse splitting like here, a lusterless nail, and we can see the brownish discoloration and even pits. So usually we don't need much of the dermoscopy in dermatitis, but really the problem arises when we see such kind of the lesions. So we are in dilemma what exactly it is. So these are the conditions which can be easily diagnosed with dermoscopy without even going for the biopsy. Like we have these 4 clinical cases resembling, and all of them can be dermatitis. But if we use a dermoscope, let us see what we are going to see here. So this is the first one. It is showing subacute dermatitis. This is the second one. It is a case of lichen simplex chronicus, with more of the whitish areas, broken hairs, and these pigmented dots and globules here and there. This is the lichen planus hypertrophicus, showing these follicular plugs, what we call as the cornpern areas, and pigmentation in the periphery, as well as the vessels which are radially arranged. Then this is the case of prurigo, where we see excoriations, this starburst appearance, adherent fabric fiber sign, and pigmentation in the adjacent area. So this is how it can make our diagnosis very easy. And again, problem arises in such cases, like we are usually diagnose these cases as pigmented contact dermatitis. Now, in this case, what we see is more of the ham-like pattern of blue-gray globules in the perifollicular and periuterine distribution. So this is a case of lichen planus pigmentosus, while this case, where we see uneven brown pigmented globules, but with more dense distribution, and a background erythema is more of the pigmented contact dermatitis. And batch testing may also be diagnosed, like we can accurately say that it is an irritant reaction, or it is a positive batch test reaction, or weak allergy, and irritant reactions can easily be diagnosed with case of dermoscopy. Then the second modality is a high frequency ultrasonography. So this is the high frequency ultrasonography is the image analysis that allows non-invasive follow-up of dermatitis. So usually we use a 20 megahertz probe that scans the whole skin, including the papillary, reticular dermis, and up to the subcutaneous tissue. And if we use higher resolutions, we can even see more detailed details of the epidermis and upper dermis. So the ecogenicity of the dermis depends upon the orientation of the collagen fibers, the ground substance, and the water content. And if there is more of the fibers in the skin, there is more of the echogenicity like we see in case of systemic sclerosis and other conditions. But if there is more number of the cells, that's in the form of inflammatory infiltrate or neoplastic cells and the water content, they all decrease to lower echogenicity. So all the inflammatory dermatosis, where we see a subepidermal low echogenic band, which is easy to detect. So this is a subepidermal low echogenic band, which we can see, and its thickness correlates negatively with the severity of the skin lesions. So this is this is lesser, this bandwidth is less if there is more inflammation, obviously. So it correlates negatively with the parameters like epidermal hyperplasia and hyperkeratosis and intensity of the inflammatory infiltrate. So it is used as an objective parameter in monitoring the course of the disease. It's another documented use is the evaluation of the patch test, okay? And we can also see that the transcutaneous edema is more in case of allergic contact dermatitis, and it's more superficial in case of irritant contact dermatitis. So we have another modality, that is the reflectance confocal microscopy. Its principle is depends on the laser excitation of the tissue, and there is fluorescence measured by photomultiplier tubes. So all these leads to dark and bright areas in the horizontal sections in the skin in vivo. So it provides a high resolution imaging in vivo in real time, and depth of imaging that is possible is very deep. That's 250 to 300 micrometer in normal skin. So this is the procedure for confocal microscopy. It's a very invasive, non-invasive kind of the thing. And this is the normal skin. So we can see in the aerial sections, the different layers of the skin can be easily made out. And the different conditions like spongiosis is shown by increased intracellular brightness by this. And then epidermal inflammatory cellular infiltrate is seen as visualization of the brown, bright round or structures, and intraepidermal vesicles appear as dark spaces in epidermis containing inflammatory cells and necrotic keratinocytes. So this easily helps them in differentiating allergic contact dermatitis from the irritant contact dermatitis. Like the inflammatory cell infiltrate can be seen in these. We can see the vesiculation and the spongiosis here and there. More in case of the vesiculation is more in case of allergic contact dermatitis. So compared to that of the irritant contact dermatitis, that's how we can make it. Then we can easily differentiate allergic and irritant contact dermatitis by these features. There is vesicle formation in allergic, while as in case of irritant, there are more superficial epidermal changes. So that helps in this. Now, sometimes the images can be deceptive, like if you see this image closely, it is Albert Einstein, but if you see it from a distance, it's Marvin Monroe. So we have to judge the images properly once we are diagnosing any condition. So same is the case with optical coherence tomography. So this is based on the principle of parallel time domain interferometry and adaptive optics. And again, we can visualize the cells in the epidermis, papillary dermis, and superficial reticular dermis in their microarchitectural context at up to 570 micrometer in depth. So it's more, and we can see it in the cross-sectional mode as well as in the M-phase mode. So we have two types, the conventional one and the high definition one. Conventional one is used as an objective parameter in grading severity of the patch test reactions, whereas the high definition is a unique in vivo, non-invasive real-time 3-dimensional epidermal thickness measurement, which helps to differentiate this irritant reaction from the doubtful reactions because of the high definition. So like this is the pictures of doubtful reaction compared to the irritant reaction. Most of the things are almost similar, except that there is no vesicle formation in case of doubtful reactions, and exocytosis in stratum granulosum and stratum spinosum is more pronounced in the doubtful reaction with these yellow arrows. Okay, so rest of the things are almost similar. One more imaging technique is the laser Doppler flowmetry. We know that the vessels and the blood flow is more in case of the inflammatory lesions. So more the inflammatory lesions, more will be the blood flow. So this is an objective and user independent assessment of the test reaction, which is obtained using blood flow measurement by either laser Doppler or the spectral imaging. And both these technologies allow quantifying the amount of inflammation at each test site final decision. So what we can see here, the perfusion image can be analyzed by an integrated system software. The relative color extends from the smallest and the largest perfusion value from green to red. Then we have the imaging mass spectrophotometry, and this is a tool to acquire high resolution image data of ions in the different layers of the skin, especially for the hapten exposure like nickel, and it can be expanded for investigation of skin distribution of the sensitizers in general. So this is the imaging which shows the levels of the nickel in various layers of the skin. So it can be used for other metals as well. Now, after showing the types of the imaging which can be used for the diagnosis and evaluation of the dermatitis, we know that there's an incredible excitement about using imaging these days in the form of artificial imaging. So artificial intelligence is used for dermatitis as well. So this is the smartphone platform workflow for artificial intelligence dermatology diagnosis assistant. So this is how the convolutional network, neural network is being used for development of these softwares. So this has been used in case of dermatitis as well. This is another this circuit showing that we can easily differentiate atopic dermatitis and other kinds of eczema from other inflammatory dermatoses. So it's nowadays being used, and various research is also being carried on this. And recently, it may replace our diagnosis. So to conclude, both the micro and the macro optical imaging techniques are currently being used in the diagnosis of dermatitis, and skin imaging may serve as a novel armamentarium tool in the hands of the dermatologist for contact dermatitis. So we may work more on this imaging techniques, and ultimately we may use it for all kinds of the dermatitis. Thank you.
Thank you, Dr. Yasmeen, for such a nice presentation with different imaging techniques and latest non-invasive method for diagnosis of contact hand eczema. Over to organizer.
Thank you, ma'am. Thank you, Suresh Jain sir, for chairing this session.